There are 1,000,000 ways to die. We just wanna talk about it. Codeheads.
Hello, everyone, and welcome to Codeheads.
Good morning.
We are here back at it again. And today we are going to discuss family presence during resuscitation. And just a little bit of a precursor is that my family is going to be present.
No way.
Yes.
Wow.
Mhm. My sister is an expert in the mental health fields, and she's amazing. And so she's going to be joining us shortly. So, family presence with family present.
Ooh.
But just to define it for everyone, so family presence during cardiac arrest is really referring to allowing family members or loved ones identified by the patient to remain in the patient care area. Um, and they can visualize, they can, be holding the patient's hand, or they can be visualizing what we're doing, like CPR and the other interventions that we're doing to help and save their loved one's life, like anything that's happening during cardiac arrest events. And, it's really offered as an option. Obviously, it's not required, but it's really to respect cultural, religious, and other individual preferences of patients when they're in this critical state. So it's the family's choice if they want to be present or not. Sometimes it helps with closure. It helps them to understand the severity of the situation and all the efforts being made to save their loved one. Do everything. Well, now you know what do everything
Yeah.
means. And as an in-hospital provider, I always think about it just for in-hospital, but that's why I love working with Mike, because he has that pre-hospital point of view as well, because in-hospital, we can, invite you in, but pre-hospital, it's kind of incidental. They are just kind of present.
Right. So we never really necessarily had the luxury of choice. If we were working a cardiac arrest, we are often in the home in front of family members already who are obviously, it's a very intense moment. They're very affected, and we are in their living rooms. We are in their bedrooms, these intimate places where they have familiarity of family. In this cardiac arrest, this moment is occurring right in front of them where they have a lot of associated memories. Conventional thought would presume that their presence would be an interference. They would be hysterical, quote unquote, that they would be too involved, that it would, affect our care, our intervention, what we're trying to do to bring them back. And I could honestly say, I can't recall one time in the 800 to 1,000 arrests that I did that they actually interfered and hindered our progress, hindered our resuscitation attempt. I found it didn't affect me at all. And in fact, it makes you be more on your game because you're under their watchful eye. And that's important because it's holding you accountable. Not that we weren't held accountable inside the ambulance and hidden, but you just know, okay, you're under the spotlight right now. This is the most monumental event of their lives. You're on display. Do it right.
Right.
And it never interfered. Like I said, never once interfered. And afterward, if it would interfere, we have police, we have the fire department as facilitators in those situations if there was a problem. And in fact, they were the communicators. All right, right now he's doing compressions. Right now they're going to intubate in order to ensure that we have a patent airway, etc. So that's the pre-hospital perspective.
All right. And as previously mentioned, we have my family present, my sister, Dr. Katie Hurley, who is a mental health expert. And she's here to weigh in on some of this, to kind of talk about the softer side, the non-clinical side that we kind of overlook a lot. So welcome, Dr. Katie Hurley.
Welcome.
Thank you so much for having me. It's fun to be on with you all.
I know. We've
You're
got
our first guest in the history of Codeheads, 21st episode.
Yep.
What? Well, I feel honored.
You'll get a special Codehead gifty,
Yep.
a nifty
I
gifty
hope
from
so.
us.
Is it a hat? What is it? I'm so excited.
It's a surprise.
It is. We're bopping around a few ideas. I think one might be more appreciated than others, but you know. um, so Mike was just speaking about pre-hospital family presence and that they're not really invited. They're just kind of there. So it's a bit of a difference from in hospital where we can offer it to families and they can say, oh, no, thanks. I don't want to see that, or sure, I'd love to be a part of it. So I don't know if you have any thoughts, Dr. Hurley, on, kind of the difference of maybe who should be present or, you know, how we should go about supporting families, especially in maybe pre-hospital where we don't have really a choice.
Right. So I would say there's a couple things to think about. One is primarily who feels like they can be in the room. So, I mean, this is a big event, whether or not a person ends up in surgery or, coded or whatever's happening, this is a huge event and can really trigger panic for people because no matter how many ads we see about what to do and how to stay calm or, how many PSAs out there or articles, etc. When something like that happens to a loved one, it panic is a normal reaction to an abnormal situation. So, and it's always unexpected, right? Nobody knows when these events are going to exactly happen. So, I would say, number one is, do people feel like they can be in the room? Do they feel like they can be present and a calming, entity in the room for the person? Do they feel like it helps them? Or is it going to help the patient? What is the motivation essentially for being in the room? So that's a big thing to think about. And, when somebody has a heart condition that's being treated, maybe that's something you can think about and talk about ahead of time. But when it's sort of on the fly, it can be really scary. And so, what we don't want is like stress contagion in the room. So if loved ones are just full blown, panicking or crying or yelling and like it can't seem to find stability or calm in the room, then that could activate the patient who's on the table fighting for their life. So, we would want to take a look around, right? Have somebody in the room, like a social worker, who can kind of take the temperature of the family members and say, you're welcome to be in here, but also I can bring you into this quiet private room. We can chat about what's happening. I can walk through the steps with you. So that way there's sort of like logical choices and they know, they can make an educated guess. And then the second thing I would really think about is age, certainly we don't want children in situations like that because even though adults may be able to work through a situation like that, deal with the distress, get some help on the other end and work through, a child might really kind of experience that as a traumatic event that is difficult to work through.
And I think you brought up actually a lot of valid points there, because we do a lot of whether it's pre-hospital or in hospital, we do so much like training. We do these mock codes to ensure that our staff know exactly what to do, and so that they're not stressed. Because despite being a healthcare worker, or EMS, it doesn't mean, well, EMS, I feel like is cut from a different cloth, but, being a healthcare worker, that doesn't mean that you like that adrenaline rush or you're really into cardiac arrest events. There's many nurses that are just, like, ooh, I go in and I do my thing. And, I don't like the unknown and I don't like the arrest situation. I like everything else. And so we do a lot of training to make sure that they can, keep it together and they understand their role so that they can focus on what they need to for the event. And then we debrief afterwards. But we don't always do that. Previously, we haven't always done that with family members. And there are a lot of places that, might allow families in, but they don't have that like guru with them to support. And I think that's one of, you're kind of hitting the nail on the head as far as like what the gold standard is for family presence. It's not just being like, hey,
Yeah.
come on in, your family members, dying and we're trying to save them. You want to come in? Cool.
You wanna help?
Yeah, stick
One
by the
thing,
head.
one thing I want, one thing I want to mention, you brought up a really good point, both of you, in fact, is when we were working in arrest, a sudden cardiac arrest within the home, and the family is present, like regardless, we don't have the choice. Following the event, because typically if they don't make it usually, right? 9 out of 10 don't make it from a sudden cardiac arrest. We don't transport these patients. So we are leaving the family member in the living room on the floor with the equipment still, say they're intubated. That tube is still there. Why? Because the medical examiner will be coming afterward. We had no choice, but we could do tender things like put a pillow under their head, cover them with a blanket to the best of our ability. And I didn't think of this before today, but following it, I really appreciated being there. Very respectful. And I actually liked, because as the medic, I would usually be lead on scene. Like isn't maybe the right word. Communicating afterward that we did all we can do. And it was revealed by example. They saw it. And so you felt good, even though it was a tragic event. And I could see in their eyes that, I don't know, there was just a moment of realization that it was over. And sometimes that's important too, is that this is finality. We're told to be blunt with tact, that I'm sorry, but they've died, not they've passed over, they're in a better place, because who knows if they are. So I appreciated that communication. Shouldn't laugh, or I'll cut that part out. But anyway,
They were a real son of a bitch.
I mean, this is actually making me think a lot about just systemically, like, changes that we should all be thinking about making in our respective fields and sort of merging our fields. So, I mean, I'm always going to talk about social work because I'm a social worker, but, with the new rollout, well, it's not new, but new and improving rollout of 988, what happens when somebody calls 988 for whether it's a mental health crisis, like I'm going to hurt myself or I'm thinking about hurting myself, is that a social worker is the first person in the door. So police will be like on site in the background in case they're needed, but a social worker or some other mental health worker or trained counselor is the first one on the scene through the door to sort of calm the scene. And I'm thinking about like, how great it would be to have, I mean, like pie in the sky ideas. How great would it be to have social workers respond to emergencies like that with you all so that there is a person who can help the people who are just feeling stressed and anxious and uncertain about what's happening in their own home, because the more we work together and we cross collaborate, the better we do for everybody on the scene, including the people like you who are trying your hardest to save a life. Like you're using every tool in your kit to save a life, knowing that 9 out of 10 number. I mean, that's got to feel impossible at times, right? Or when you have time to think about it.
Right.
But it also reminded me of, and this is, different situation, but when I was going through cancer treatments, my mom insisted on coming to a chemo treatment with me. And I knew she was going to hate it because she hates hospitals. She, these ththings freak her out. Medical stuff just totally freaks her out. And so I was going to actually have my sister come, and then she really wanted to come. And I was like, oh boy, she wouldn't come in the room for the first 20 minutes. It was like she was, dancing around, nervous. Mom, it's going to be okay. At some point, I'm knocked out on Xanax because I have this cold cap on my head. So I'm kind of like in and out of sleep. And I wake up at one point, and the social worker is just sitting with my mom for, over an hour, just chit-chatting with her about things and stuff, a little bit about me, a little bit about cancer, asking her about her own life. It really calmed her down. The next thing I know, I wake up and she's got like this, fruity drink in her hand with an umbrella in it. And she's chatting it up with the nurses. And it's like, okay, this is, this works. Offering support to people so that the patient doesn't have to be the support. Also, it's like that stress was taken off of my shoulders by, a social worker and a nurse.
Yeah, and
Good
that's,
stuff.
and when we do training and whatnot, sometimes I have, and not sometimes, a lot of times I bring in, even though we're working on a mannequin and whatnot, I'll have someone be like, hey, be a family member. And, be like, just like really shell shocked, like quiet shell shocked, see what they do. Or just be freaking out and screaming at them and just like losing your mind, and I'll be like, just be in the corner, see what they do, to kind of just test and see how they respond. And even though we're simulating and we're not, doing it in real life, I want to see if any of them are going to, use their softer skills and kind of go and support. And a lot of times they're kind of just like, get out of here, like, because
Right.
they're, so focused on the other things. And they're just like, but someone will eventually help and step in. But that's one of the reasons that, in hospital, when I was leading our cardiac resuscitation department, or emergency cardiovascular care department, I got pagers, code pagers for the social worker, and pastoral care on call. That way, at
Mhm.
least one of them would come, but they both had those, we loved it when the social worker came. Pastoral care was great, but the social worker had a little bit more clinical knowledge too, to be able to like hold the family member's hand. If they wanted to stay in the hall, that was fine, and they would kind of stay in the door and be like, "Okay, well, do you wanna know what's happening? Do you not?" Like, they were such a
Yeah.
great bridge, and it allowed the families to still have that closure and to still kind of have that experience and knowing everything's being done, but they had someone that was able to, like, help them, you
Facilitate.
know
Mhm.
yeah, and, talk them through learn a little bit more about the patient who's arresting,
Yeah.
and so sometimes they would come in and tell us little things and be like, "Hey, he really liked," even if they weren't making it, that he really liked this and maybe talk about that or whatever, even though we're doing everything.
Mhm.
Sometimes the respiratory therapist by the head will, who's, ambooing will talk about like golf or whatever, "Hey, a
Yep.
cardinal flew by," whatever, if they're a bird watcher, to try and just help and support and meet those cultural, needs of that family, to make them feel better about what was happening. Because it is, for our we look at it so clinically, but it really is traumatic seeing a lot of the stuff that we do. It looks barbaric and horrible.
Yes.
Yeah,
Yes.
it
That's
does.
why I think conventional thought would say, get them out of here, because
Mhm.
we are doing ugly things to these people, but which are necessary. Ironically, we have
Mhm.
to harm them to bring them back. And
Right.
I
Yep.
would just presume I don't want to see that. I do not want to see that, but I can't speak for the people that are there, right? It's not my
Right.
emergency. It's theirs. And,
Right.
you know, that's why if I'm glad it wasn't up to me to make these decisions, because I wouldn't have thought that this is an appropriate action to take. And it turns out the studies have shown completely otherwise, right?
Well, that's what I was gonna say. There have been so many studies because we didn't allow it for so long, and
Right.
then some people got really, like, mad and angry and upset, and I absolutely appreciate that. Um, and, we were like, "Oh, we know best." But then, it comes to pass that people would have PTSD and severe anxiety, and, they wouldn't wanna return to hospitals because, "Oh, my mom went in that room and then never came out and died," and it's like, "Oh,"
Yeah.
like, we didn't think about that flip side, and so that's why now allowing them in with a facilitator has shown a decrease in anxiety, a decrease in PTSD, a decrease in depression. And, and it also has helped them with that healing process because we debrief with them. We give them, the
Right.
time to start like understanding and processing right then and there.
Yep.
Yeah, and I think a lot of people feel very strongly about not wanting their loved ones to die alone. That is something people think about when someone is sick, whether it's sudden onset cardiac arrest or cancer or something else. They really do think about like, I don't want them to have to cross over to whatever happens next on their own. And we do this with our pets. We do, I mean, we're in the room with our animals when they do, so why would we not be in the room with our people? And I think
Right.
that's just something to think about in terms of, compassionate care in those situations.
Yeah, and that's, and it's something we do with every other end of life kind of stage is that, even if someone's passing, it's unexpected and we're waiting for family members to come in. I can't tell you how many times I've gone into a patient and I'm like, okay, I will go and sit with them, in critical care, like when I know we're just waiting and being like, okay, Sally's flying from the West Coast. She'll be here in a few hours. We can do
Yeah.
this. We're going to wait for Sally. And she called and, and I give them updates on the whole family. And, I'll talk to them about all sorts of things because they can still hear.
Yep.
Yeah.
Things are still happening, even though,
Yeah.
we know that the end is nigh, as it were.
And they can still feel.
Um,
And
Yeah.
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 And
It,
it's important to support that.
it's reminiscent to me. I mean, this is a comparison, but it wasn't that long ago where men were isolated from labor and delivery,
Yep.
where
Mm.
that was a sudden change because my father, so I'm born in 74. My father's in the waiting room with that image we would see on cartoons or TV, pacing back and forth. And in fact, he had paced back and forth so long, he went to the bar across the street. It was taking forever. And I just, that changed swiftly because come 2009, when my son was born, we're all invited in. Oh, bring her
For
mother.
your neighbors.
And
Yeah.
to be totally frank, though, what we're talking about is a choice. And if I could choose again, I wouldn't want to be there because I've so connected to it, and I just imagine disaster. It's true. So I'm someone that should that would choose not to be
I
there
can see
next
that.
time, and I'd love
Yeah.
to be in the waiting room or the bar across the street.
Maybe
Yeah,
there
I
with a
can
baby
tell.
dose of Xanax.
Yeah.
Yeah,
Oh,
I can have that option, or yes, hook me up. But
yeah.
Well, because that brings up an important point, though, which is motivation, human motivation, right? So we think about human motivation on the side of the person who's the carer or the support person in the situation, but childbirth is one of the most physically and emotionally traumatic things that women endure, and they push it out and then they go back to living, like
Yeah.
nothing happened. And so having a
Ugh.
support person in the room is important, and that's why that shift was made, because why
Yeah.
should women be doing this with strangers or a doctor they've met a handful of times along the way?
Right. No, it's all
That's a
valid.
traumatic event. I mean, that could be viewed as a traumatic event, of course, right? The pain, the
Yeah.
agony, duration. I'm not
Oh,
speaking from your
don't even get me
experiences, but
started.
I marvel at it. I mean, seriously, like
Yeah.
that's a hard thing to hard's an understatement. I'll stop. I don't want to speak for women.
Thank you. I appreciate that.
Sorry.
But I do think, getting back to family presence, I think that, that's one of all the things that we've kind of touched on is one of the reasons that, the ILCOR, the International Consensus for Resuscitation, I jumped over some words there, but also the American Heart Association, have made it part of, their guidelines for cardiac arrest is to offer the family being present and have, something set up. So we really do need institutional policies and, staff preparation and awareness and, and that's for pre-hospital too. I always speak so in hospital, but for pre-hospital too. And it sounds like you guys do. I know that I know the fire department, when I do ACLS courses with fire departments, they talk so much about, the interpersonal skills and talking with family members. And I'm sure, others do it as well. But it really is important to have, a designated person and with those skills. And I love the idea of, collaborating with 988 and having social work come and be a part of it.
You
Um,
great point, because honestly, we were never trained on how to deal with potential family members on scene. So you basically had to have baseline interpersonal skills. And I'm telling you, not everyone does in that field. They might be a great clinician, but they suck at talking to people. And to me is a big part of the job, right? I mean, it's
Yeah.
For sure.
immense. I mean, I might not be as good at starting IVs as this person, but I know how to talk to people. And that can be put into the training, but it's not. It's really, or it wasn't when I was in the field
and
50
it's
years
still
ago.
not. It's
Yeah.
still not because it is, we're moving to offline or online learning, and they're trying to pump people out because there's no one in the fields, and
Right.
Right.
you do a whole podcast just on that alone. But I think we've covered a lot and we've talked a lot, and I hope that we've given people ideas and thoughts and what to do and how to maybe reinforce and make their family presence policies more robust, or create policies if they don't have them, and how better to support family members. So thank you, Dr. Hurley, for being with us and for
Thank
being
you
our
so
first
much. That was
Codehead
wonderful.
guest.
Hey,
It's so
thank you for having
exciting.
me.
Yeah, and so you
fun.
get to be a part of our outro. Ready? Who's ready?
I'm ready. What do I do?
We'll see you next time. You get your
Spontaneous.
Codehead dance on.
Yeah.
There are 1 million ways to die. We just wanna talk